So we have the next session on optimizing diabetes care with early insulinization and switching to an affordable basal insulin. And we have a member of our organizing committee, Dr. Archana Sarda. Everyone knows her over here, a consultant diabetologist, very passionate about type 1 diabetes and insulin therapies. Over to you, Archana, for your talk.
Thank you, Dr. Anjali. I'm the last person in this therapeutic session, and yes. So the topic today is optimizing diabetes care with early insulinization and switching to an affordable basal insulin. This talk is supported by Biocon. So let's look at directly in the clinical scenario, what happens in our clinic. We have already been talking about initiating insulin, intensifying, talking about premix insulin. And now let us shift to a patient who is in our clinic, say Mrs. X. She's 48 years old, female with a history of type 2 diabetes since 4 years and a known hypertensive on medication since 3 years, has pain, burning feet, nocturia and occasional itching, general weakness. She's on glimepiride plus metformin, 2 plus 1000 milligram twice a day. So that's 4 milligram and 2 grams of metformin. Tenagliptin she's taking before food. Earlier, her HbA1c was 8.4, and that is when this was added. She's also on telmisartan and amlodipine. Her blood pressure is 136 by 80. Her sugars are 180 and 220. The HbA1c today is 9. Her BMI is 26. Lipids are normal. UACR is 28 milligram per gram, and serum creatinine is 0.8. ECG is pretty good. So she's a known case of hypertension, and her diabetes is not controlled. Now, how do we say that the OADs are inadequate? So there are various guidelines, there are various ways, and ultimately I believe it's also your own clinical judgment. When would you like to shift a patient to insulin? But as long as we are all conscious of the scientific guidelines, as well as our own inertia is not the reason, we are good with the guides. So the 2 OADs used at maximal doses, sometimes we can 3 or more can be your guideline. Significant insulinopenia, glucotoxicity, that is definite reason to go on to insulin. Increase in hyperglycemic symptoms, weight loss, and HbA1c, which is constantly above the individualized glycemic target. So whatever target you have set for your patients and not able to achieve, that could be a reason that you would like to insulinize your patient. So when would you consider insulin in a person with type 2 diabetes? When a combination of non-insulin anti-hyperglycemic medicines are unable to achieve those targets. And how long would you wait? I think that's another thought that one has to have. So it's not just your glycemic target, but also a time target, because we all know that the patients would come in and say, next time, give me another month, because they don't want to go on an injectable regime. But what are those targets? And when non-insulin medications are associated with unacceptable adverse effects, this happens quite often. People are not able to tolerate the various OHAs that they are prescribed, especially when they also have so much of other medications for comorbidities, advanced hepatic and kidney disease, special considerations, as we saw in the COVID times, with the steroids, infection, pregnancy, hyperglycemia in a hospitalized patient for whatever cause, usually would need insulin, and presence of severe hyperglycemia is one of the indications. Now we have so many insulins, I don't need to share this with the entire august audience here. The rapid acting analogs, the shorter ones, the intermediate, and in the long acting, we have the basal glargine detemir and the ultra long basal, the glargine U300 and the 100, as well as degludec. So we have such a wonderful choice. I think in this 100 years of insulin, we have really come a long way, and we have a choice on what we would like to start, and judicially, when would we like to start what, and which is our own clinical choice. So what does the ADA Standards of Care of 2021 say? It says that consider the insulin as a first injectable if the blood glucose is more than 300 and the starting HbA1c is 11, right? And the evidence of ongoing catabolism is there. You can see the weight loss, and often patients would come to us with that kind of presentation, the glucotoxicity, and the other symptoms of hyperglycemia are present, could be your indication for starting insulin. And initiating with basal insulin is validated by basal insulin being the most convenient initial insulin regimen and can be added to whatever is the existing oral regimen and metformin. One could start with 10 units a day, or it could be 0.1 to 0.2 international units per kg in a day. Patients who are on GLP-1 analog, we can add basal insulin if the A1C is above target. And for patients who are on the GLP-1 analog and basal insulin considered with fixed dose combination, we can think about it, but we have to note the maximum dose of insulin in these fixed combinations. What do the Indian guidelines say? The RSSTI guidelines also talk about initiation and titration of basal insulin, starting with the basal insulin when the HbA1c is less than 8 or above 8. That can be with 0.1 to 0.2 units per kg weight or 0.2 to 0.3 because our targets are higher. I think everyone will agree that monitoring and up titration or down titration will be very important here. So the titration can be every 2 to 3 days. Initially, we wait for 4 days for it to reach a steady state, and then up titration by 1 or 2 or 4 units as per the situation. And this has to be taught to our patient, and maybe you can have a follow-up phone in your own clinic for that. Monitoring for hypoglycemia has to be explained to the patient on day 1, and the reduction of the doses, because often if it's not explained, it could lead to discontinuation of insulin, which is something we would not like. We have to explain to them this is a natural process. So when we are talking about basal versus premix, we have glargine with OADs, or we can have twice daily premix. So if we look at various studies, and this can be, the jury is out, we just heard a talk on why premix is good. So again, I think it's all our clinical judgment, but the mean adjusted HbA1c improvement was greater with glargine and OADs than with premix insulins. And the rate of confirmed hypoglycemic events, I think that is a big thing which makes us want to use this, was 50% lower with glargine plus OADs as compared to premix. Symptomatic as well as nocturnal. So documented symptomatic nocturnal, all hypoglycemias were 50% less. So I think that's a big, big achievement that we would like to have for our patients. So if we really look at insulin, which is premix versus basal insulin, and then more than one injections are needed when we are going for premix. Of course, we are talking about early insulinization. If you're not doing it very early, we also know that we may not achieve what we want with basal insulin. Then higher doses are required. We need to adjust for meals and exercise, and they're associated with more weight gain and hypoglycemia. These are two very, very important factors that we are talking about every day with every drug. More convenient to go for a basal, lower insulin dose is required, less complicated because it's not related to their meal and exercise, and much less hypoglycemia and weight gain. So this is something we find very, very convenient and well accepted by our patients. So this is a convenience initiation for the doctor also. So we just start once a day, can be early morning or in the evening. It can be just 10 units. Check the fasting blood sugar, set a target, and up titration can happen by 2 to 4 units. Twice a week is usually how we do it. And again, the HbA1c can, once it is reached, the HbA1c can be again checked after 3 months, and again, the regimen can be redesigned. So a lot of interaction and education needs to happen, but it usually does very well with our patients. So in this particular patient, the HbA1c of 9%, symptoms, age, and comorbidity, the patient was counseled to start insulin. And because it was chronic, the important thing is also the cost of therapy, right? So she wanted something which is affordable, and she was started on a biosimilar insulin. Today, we are going to talk about biosimilar insulins, and she started on a biosimilar of glargine, 12 units at bedtime. Glimepiride and metformin was continued, telmisartan and amlodipine was continued. And when she was followed up, as one can see, ultimately at 2 months, we found that she is on glargine 20 units at bedtime with the HbA1c of 7.4. The fasting is 110 to 130, and she has gained just 1 kg weight over this time. And she is now advised to continue the same dose with regular monitoring and exercise and a follow-up after 3 months. So we do want to initiate our patients onto insulin, and especially glargine basal insulins, but they are also very expensive. So I remember that we had a lot of discussion at many forums on this and talking about biosimilars, but ultimately, affordability, accessibility, availability do matter. And if you look at the affordability scenario, and if we can just see here that between 2000 and 2013, the average price has really tripled. Now we also know that this tripling is also because we have better and better insulins, more modified. A lot of research has gone into it, but the price is increasing, and ultimately it means it's out of reach for most of the people. And if you look at these numbers, it's huge. 33 million people do not have access to insulin, and it is projected that by 2030 it will be 41 million people. So especially in Asia, and if we talk about Africa, people who really need insulin and do not have access, it is also predicted that it won't be possible to have that much production as well. So is biosimilar the future? And that is why we have to think about, because we want to insulinize our patient, we want to give it affordable, we want to reach out to everyone who should be on insulin. So what is the future? And you have the biological product, which is similar to the reference product. And then we have to think of the physiochemical characteristics. Again, the similarity to a reference product is very, very important, whether it is pharmacokinetics, the immunogenicity, and the additional clinical studies which are needed. Then approval is something we seek for by the FDA, and it can only be obtained by a rigorous evaluation and testing. Again, the functional characterization will come with studies when we actually use them in our patients. I remember there were a lot of debates in a few of the conferences 5-6 years back whether we should use biosimilars or not. That time our concern was immunogenicity, it was the quality of the product, it was the lack of studies. And I remember that we were always saying that yes, we want to, affordability is a great point, but what about the science? So if you look at the similarity in biosimilars versus their reference so it's absolutely a very, very, as I will be showing you later, the rigorous process of science that it goes through, whether it is the host cell line, the manufacturing process, the protein structure, the inactive ingredients, and the similarity to the efficacy, to the reference biologics. So the amino acid sequence and the mechanism of action is what matters, and that between the two has to be similar. Now, we often think it is just copy. I mean, I'm being very light here, but people often say it's just copied molecule, but it's not like that. It's a lot of development. When you have a research molecule development, but the biosimilar development also undergoes the entire process, maybe in the reverse direction, because you have to have clinical studies, the pharmacology, the PK/PD has to be established in vivo studies and in vitro studies. So demonstrating the safety, purity, and potency is very, very important for a biosimilar. Now, overcoming the challenges with the biosimilars as compared to the original molecules. So affordability is covered. The late insulinization can be taken care of. The complications would automatically come down, and again, cost, which is the major hurdle for us, would be taken care of. So if you look as a physician and we look at a biosimilar insulin, we want to choose the right biosimilar, but which one would we choose? So the indication, of course, but the the economic impact, immunogenicity testing would be the very important factor. The efficacy studies is something we would like to have so that we can trust something as a biosimilar. So what is important to understand, that we are concerned, but is it similar to the reference molecule? Is there no clinical significance difference between the two? The variability of a biosimilar has to be between the standard limits. The equivalent quality and safety and efficacy studies have to be there, and very stringent regulatory approval. So do we have clinical evidence? Yes. So there is a study in Type 3. This was to assess the efficacy, the insulin dose, safety, and immunogenicity when people with type 1 diabetes switched from Biocon's insulin glargine and reference insulin glargine. Why are we talking about Biocon's insulin glargine? Because that is the first one now to get FDA approval for interchangeability and switching, which is something that we have to understand. So this was what happened, and it's a very robust design with followed over 36 weeks, and patients were given Biocon insulin glargine, or they were given the original glargine. And the end of the trial visit after 36 weeks and follow-up after 48. What actually happened? The HbA1c changed, and the change in baseline to week 36 with Biocon's glargine was equivalent to the reference insulin glargine. So first is the glycemic efficacy that we're talking about. Then the very important factor was hypoglycemia. So anytime hypoglycemia events were comparable with both the sequences throughout the study. And when we look at this, we also looking at immunogenicity. So glargine demonstrated equivalent efficacy, safety, and immunogenicity, demonstrating that the patients taking the reference glargine can now be safely, though, and the ones who were switched to Biocon's insulin glargine were equally safe when we're talking about the safety from the immunogenic point of view. And that the proportions of patients who met the criteria of cross-reactive ADA positive response or the total ADA positive response was similar in both groups at all times. This is something which is our concern for immunogenicity, which was the main concern when we are using biosimilars other than the similarity in all the clinical outcomes. So comparable immunogenicity profiles in two groups. Majority of the patients were negative for total ADA. Majority of the patient with type 1 diabetes were positive for total ADA, consistent with the previous studies, and no occurrence of therapeutic neutralization and hypersensitivity factors. So where do we stand with biosimilars? So EMA has led a way in biosimilar approvals. They have pioneered the regulation of biosimilars. Over 10 to 12 years, the European Union has been getting a lot of experience of biosimilar use and their safety. And they have evolved a product safety specific to biosimilar guidelines like the insulins. So the EMA and the European Commission, the medical practice of changing one medicine to the other, that is what they call interchangeability. So I think this is something we need to understand. I will just take it forward because we're talking about the EU, the FDA, US Congress, and the WHO. So if a project is meeting all the clinical and the immunogenicity and the safety factors and can be used in the same scenario, it is an interchangeable product. This usually happens at the pharmacist level. And if a doctor chooses to change the product in their own prescription, that is switching. So switching is not necessarily prescribing one thing and using the other. It is basically approved, discussed with the doctor, and because of cost purposes, availability purposes, or any other reason, at least there is an assurance that the product that you are receiving is having the same quality, the same pharmacokinetics as the research molecule that was being used earlier. So there are recommendations that the individuals which are well managed on existing insulin should not be changed to a biosimilar insulin without good clinical reason, evidence of interchangeability, and informed agreement with the person with diabetes. So when we are using a biosimilar, we should be really sure that they have been approved for interchangeability. Right. So if you look at the FDA guidelines, and this is something the FDA approval that was attained by the Biocon glargine for interchangeability and switching. So US FDA approved the first interchangeable biosimilar insulin product indicated to improve glycemic control in adults and pediatric patients in type 1 diabetes and in adults with type 2 diabetes. So the interchangeable biosimilar product may be substituted for the reference product without the intervention of the prescriber. So again, to understand this better, so if we are now, again, I would like to emphasize that it does not mean that we are just changing for whatever we are using, or we're not talking about brands. It just means that today we have approval that empowers the patient by helping increase access to safe, effective, high quality medications at a potentially lower cost. And if at all a substitution has been done, then they know that the safety and the efficacy of that interchangeable biosimilar product is as much as what they would have used as the reference research brand. So I think this is something we have to understand, because there are a lot of biosimilars, and choosing between them and understanding that we can safely give our patient what we really want to give when we are using a basal insulin. And these factors help us scientifically to be assured that we are giving our patients a good biosimilar in basal insulins. Thank you so much.
Thank you so much, Dr. Archana, for that wonderful presentation. Indeed, the research and the advances in the biosimilars is one of the game-changing and very important researches, especially like in country like us. My husband is an oncologist, and I know how much impact the biosimilars and the generic medications. Of course, they are not together; they are totally different. I understand, but they make a huge difference in the acceptability of the treatment to patients who cannot afford the original molecules. And with the same kind of efficacy and safety, we are very happy to have molecules like that. So there are no questions in the chat box. Let me check once more. There are no questions in the chat box. So here we can summarize this sessions on